Merry Christmas, everyone. It will be very soon. Yeah, hi Simon. Good morning. Just pop your little message up there. Happy Anatta Monday. I did get a comment that my microphone was a bit um, quiet, so I've turned it up all the way as far as it can go. Um, you can bring games in, and you're allowed to wear whatever you want. No problem at all. Yeah. Morning. Hi Tracy. Good morning. Got a few of you in this morning, and we are going to be here next Monday as well. So hopefully we'll get a few of you. I think the only time that I won't run it on a Monday is if it falls on Christmas Day. I don't think I'll be very popular if I do that. Good morning, Penny. Me too, to be honest. Yeah, it was a bit crazy this morning getting everything ready. There's loads of stuff to prepare for this one, so yeah, it was a bit crazy this morning. Morning, Alex. No work for 2 weeks. Yay! Good, good, good. Okay. So what have we done so far? So we've had a look at the bones, bony landmarks of the knee. Then we started to have a look at the passive structures. So we looked at the ligaments, and I think that's as far as we got really. So the medial and lateral collateral ligaments, and then the cruciate ligaments of the knee as well. And there are some other ligaments in there too. So there are some ligaments that attach onto either side of the patella, and sometimes you can have issues with those, but generally if you're going to get any problems, it's the medial lateral collateral and the anterior posterior cruciate ligaments that you're going to have problems with. So that's why we focused on those. There were some questions as well, and I posted some papers in the group. It was about the blood supply to the meniscus, so hopefully they were useful. And I think those were all the questions that were covered from last week. So yeah, if you've got anything this week, pop anything afterwards or during the session. I'll see if I can do it whilst we're going. If you have any questions live, then if I can't answer them in the live session, then I'll search it up and I'll pop it in the group. And here he is. Stevie's here as well. Good, good. And old Walt Fritz doing the Steve technique. That made you famous. They're good. Cool. So let's get going. Just make sure we get the right ones. Here we go. So what I wanted to, in fact, before we do that, let's just switch onto this one. Yeah. So I wanted to finish off the passive structures. So the only things we missed off, I think, were the bursa and the joint capsule, and that kind of links in as well to the and the patella tendon as well, because the although it's called the patella tendon, um, by proper definition, it should be a patella ligament because it attaches bone to bone. And although it's a kind of continuation of the quadriceps muscles, it responds differently to a lot of the other tendons that are in the body. So when you do some research around about Achilles tendinopathies, gluteal tendinopathies, that kind of thing, those attach the muscle into the bone. But yeah, the patella tendon is a bit different because you've got the patella in the way, and it's the bottom of the patella, so the apex of the patella, that then attaches onto the tibial tuberosity. So it does go bone to bone. So sometimes it's called the patella ligament, and it's not so much of an energy storage tendon like the Achilles that attaches the gastrocnemius onto the calcaneus. So we've covered Achilles before. We haven't really covered the glutes yet because we've not gone up into the hip. So hopefully you'll see the differences between the two as we go through. So joint capsule. First of all, let's just have a quick look at that. Morning, Dan. Good to see you on here this morning, mate. So let's have a look. Make sure I've got the right one. Yep. So this should be the joint capsule. Yeah. Here we go. Let me just rewind this a sec. Get you a bit of an orientation. So there's your patella. So we had a look at that over the last couple of weeks, and this is your patella ligament or patella tendon, and then this is the so you got your femoral condyles at the top there, and then your tibial condyles at the bottom, and there's your fibular head. So enveloping that whole knee joint, there is a quite a tight fitting capsule, and well, it's tighter around the back than it is at the front because obviously you don't bend your knee back. Well, you shouldn't bend your knee backwards into hyper extension. So the back part of the capsule is quite tough, quite fibrous, whereas the front part, because the knee flexes, has to have a bit more flexibility, a bit more give in it. So similar to the shoulder capsule, when you get to that, or if you want to review some of the videos we did before, there's a lot more capsule tissue on the undersurface of the joint because the arm has to be able to lift. So if there was very little capsule there, then you wouldn't be able to lift your arm up. And it's the same with the knee as well. So if the capsule was tight at the front, you wouldn't be able to flex the knee or bring your heel back to your bum. So let's have a look at this. Just move that out of the way. So there's your capsule, and we mentioned this a few times when we were looking at the ligaments. So there's your MCL, your medial collateral ligament. So we looked at that in a bit more detail last week, and the capsule attaches to the medial collateral ligament. So this is literally, it's the same. There's slight differences in the structure, but it's basically continuous with the medial collateral ligament. And so there's the medial collateral just there. So this is all capsule, but if you have a look at the lateral collateral, it's underneath, and we mentioned that a few times as well. So there's no attachment on that lateral collateral. This is the back of the knee joint, so this is really tough. It's thickened to help with prevent hyperextension. So you can see as they move the knee there, and just move that back a little bit so you can see. So as they move the knee into hyperextension, you can see that all of the capsule gets really tight at the back. And this is a look inside of it, so you can peer in there, and it's lined with synovial membrane. Yeah, so it's really glistening inside there, and the synovial production is brought about by movement. Right? Cruciate ligaments covered in synovial fluid, part of that capsule as well. Okay, so you can see how everything is lubricated in that joint. And I don't know what kind of image you had in your mind about what a capsule was like, but it's a lot thinner than you think. And there's the fluid in between helps that glide in between all the different surfaces. So yeah, let me just play that last bit again where you kind of got a view inside. Okay, so this bit where they've cut through the capsule. So there, where you can kind of peer inside, you can see how lubricated that area is. And then that's the back of the knee joint again. So we can have a look at the how the cruciate ligaments are covered all in there. Okay, so again, it's to help get that glide and slide of the ligaments across each other, so they don't get stuck to each other. Cool. So that was the joint capsule. And then the other thing that I don't think we got to look at was this one. Wrong screen. Here we go. So I'll just pause that there. So there's your patella again. These are your quadriceps muscles. We're going to cover these in a bit more detail today. So you've got a quadriceps tendon at the top, which attaches to the top of the patella. So all of your 4 quad muscles attach in the top there. Then you've got your patella in the middle, and then the patella ligament or patella tendon, whatever you want to call it. And then fibular head is just here. And then that one there is your LCL, so your lateral collateral ligament. So Penny's asking, does let me just pop this up here. Does the capsule attach to the cruciates? It doesn't physically attach to them. It will surround them so that you'll get synovial fluid into the knee joint and help the cruciates glide across each other. Okay, so because as you straighten and bend your knee, they'll glide and twist across each other. And you'll see why in a second with the screw home mechanism of the knee. So it's not just a hinge. There is a roll and a glide and a twist as well in the knee. So there needs to be some lubrication so that they glide across each other. So there will be an attachment at the back of the capsule. I don't think there's one at the front. I don't think it's attached at the front, but there will be some blending of the cruciate ligament, the posterior cruciate, with the posterior part of the capsule. Okay, so but it's not usually injured in the same way as the medial meniscus and medial collateral ligament is. Okay, so if you have a valgus knee injury, you usually injure the MCL, the medial collateral, plus the medial meniscus, and you may have some irritation to that joint capsule as well because they all blend in together, just because of the mechanism of the way it gets injured. But on the posterior aspect of the knee, if you're having something so traumatic that you would injure the capsule, you would injure a lot of other structures as well, because your knee would literally be hyperextended forward. So yeah, it's unlikely that you're going to get kind of two injuries in that area because of the attachments. It's yeah, it's more to do with the medial collateral. But yeah, it's a good question. Just pop that there. Right then, so let's have a look at this. So this is your patella tendon at the front. So quads tendon, patella in the middle, and then it turns into your patella tendon at the bottom there. So that's the apex of the patella, and that's what it looks like there. So if I just move me out of the way, there's your capsule at the front. So the capsule's been cut there so that you can see the side of the knee. If I just take this back a little bit. So there's your patella tendon or patella ligament, and there's the capsule there. So you can see how quite loose it is at the front. And there it is there. So there's the joint capsule cut at the front as well. And there's a space just behind the patella tendon. I'm just going to pause that there. Okay, so we've got a couple of things going on here. So at the top of the, above the patella, sitting in, you can't really see it on this model, but if you imagine that the kneecap wasn't there, so that was taken away, and you could just get into that femoral groove in there, there's a bursa in there. And what happens is when you move the knee backwards and forwards, obviously the patella will slide in that groove, and there is a bursa underneath the patella to help with that gliding and sliding. And a bursa is, if you've not heard of those before, they're like a fluid filled sac that assist in the glide of something where there are two surfaces that rub together. So if the bursa wasn't there and the patella just kept on rubbing, then you would get a lot of wear on the femoral condyles and also on the undersurface of the patella. So we've got a suprapatellar bursa, or sometimes called the quadriceps bursa, and it sits under there. There is a little muscle that attaches onto that bursa, the suprapatellar bursa, so this one here, that when you extend your knee, it lifts the bursa up. Okay, so there's like a suprapatellar pouch. There's like a space around that area that's full of fluid. And as you extend the knee, there's a little muscle on the top, and we'll have a look at it in a sec. You don't usually see it on dissection, but it will lift the suprapatellar pouch out of the way so that the patella can glide. Okay, so it's called articularis genus. We'll have a look at that in a second. I've got a picture of it. And then in this space here, so in that one there, in a living body, that is normally full. There's not normally a space, and that is filled with fat, and it's something called Hoffer's fat pad. Okay, so underneath your patella and underneath the patella tendon, there is a space that is filled with fat. It is highly innervated, so there's a lot of nerve endings in there, and you can get some injuries to that fat pad with a hyper extension of the knee, because it will get pinched, and sometimes it can get confused with meniscus problems. Okay, so if you it's another what we call differential, so another part of your clinical reasoning for injuries or pain from the anterior part of the knee. So it could be medial meniscus, lateral meniscus, patella tendon, or Hoffer's fat pad as well. You can't really tell the difference between any of them unless you've got some kind of imaging, and the imaging that you can use on there is ultrasound, because ultrasound can pick up inflammation. So and you can see Hoffer's fat pad really nicely because on ultrasound it lights up really bright. Okay, so you can see it no problem at all. How does a bursa and a fat pad differ? So a bursa is more like a connective tissue, so it's more collagen based, and a fat pad is literally just that. It's just fat. So it's a different kind of structure. The connective tissue isn't as innervated as the fat pad. Okay, so there's the fat pad has got a lot of nerve endings in. So if it gets irritated, pinched, then it can be quite painful, basically. Okay. So here's another question: is that anything to do with housemaid's knee? Not the bursa that we've just talked about, but there is another one that's on the front of the patella called the pre-patella bursa, and that one is housemaid's knee. So if you've not heard of that before, if you Google housemaid's knee, and you'll see that there are pictures with a really big swollen front part of the knee, and it's because there's a bursa on the top of the kneecap, and when it gets irritated, it gets full of fluid. You have what's called a bursitis, so it gets inflamed, and they can get quite big. And there are some pictures online where they are massive. So yeah, the suprapatellar bursa is the same structure as the pre-patella bursa, but it's different to the fat pad. So the fat pad literally is just fat, and that's it. Okay, so it kind of fills a space, and you'll find that in the body actually. So if you do get to go to the anatomy labs, you'll find that cavities in the body. I mean, I'm pointing here because that's where I did my dissections. Spaces in the body get filled with fat. Okay, and there'll just be fat deposits around just to fill up the gaps, basically. Okay, so yeah, but that one there in particular is called Hoffer's fat pad. There is another fat pad deep to the Achilles tendon as well, and that can often get irritated too. So where there are spaces like this between ligaments and the bones or the joints, they often get filled in with fat. Okay, so that's that. So yeah, so you can see how the capsule kind of fits all the way around that joint and how it all glides together. There we go. I think that was it for that one. Good, cool. Some good good questions as well. Right. I'm across a couple of screens at the moment, so make sure I get the right one. Here we go. Good. Right then. So yeah, the joint capsule. Just move that up there. Move me out of the way. So yeah, joint capsule, largest joint space in the body, and a couple of things to be aware of with here is you can get a bleed into the joint with a traumatic injury, and that's called a hemarthrosis, and it is a medical emergency. It's often when the popliteal artery becomes ruptured, and then you'll bleed into the joint space, and basically the knee will just start to swell and it'll be hot, and that if you don't get them to hospital, then they'll bleed out. So it's usually traumatic injuries like in rugby or football, something like that. Okay, so just something to be aware of. Made up of an external fibrous layer, internal synovial membrane, which is what you've just seen when it was cut through, and all of the internal surfaces that are not covered by articular cartilage. That's what it basically covers. Attaches to the femur and then the tibia, and then there's basically synovium everywhere. And even though the ACL and PCL are known as intra-articular ligaments of the knee, they sit on the outside of the synovium. Okay, so although they still are lubricated by the joint capsule. Okay. Just get rid of that so you can see that a bit better. There we go. Synovial membrane has a pouch above the patella called the suprapatellar bursa. So that's what we've just been looking at. There is a test that you can do. It's called a sweep test. So if anybody has any swelling on the knee, then you can sweep up the swelling into that suprapatellar bursa. So you sweep up on that and do the right side on the medial aspect, and then you're basically pushing any fluid that's in the capsule up into that suprapatellar bursa, so that pouch, and then you observe the inside of the knee as you then sweep down the lateral aspect to see if anything pops through onto the medial side. So you're basically clearing the capsule on the inside. You hold it in that position, and then you sweep down the left, and if there's any fluid in the knee, it will pop out on the medial side. And that's quite a crude test to do, but it's pretty good to determine whether there's any kind of fluid in the knee capsule. And friend of ours, Al, he's been on the call quite a few, been on this quite a few times. He used to work at Liverpool. And if a player was coming back from knee injuries, then the physio would do a sweep test to see if there's any fluid coming out on that medial aspect. And if there was, then they didn't play that day. They would go and do something else because there's obviously some kind of irritation still in the knee. So it's a useful test. That's called the sweep test if you've not heard of that. Penny's just asked, is there a test for the fat pad under the Achilles tendon? Other than squeezing it for just palpating and ultrasound. So if you squeeze it just underneath the Achilles, then it might be a bit tender. There's nothing else there apart from that. If it's superficial on the Achilles, then it might be a bursa. So you can get a retrocalcaneal bursitis. That space underneath again is filled with fat. So it's other than ultrasound, you can't really tell. Palpation is fairly useful, but it could be some other structures. So it wouldn't give you a definitive idea. And then Stevie's asked, is it like a lipoma? It's not really. So a lipoma is usually contained within its own connective tissue, and a lipoma is usually in an area where there isn't usually that amount of fat. So it's kind of like a self-contained fat globule. That's what a lipoma is. Whereas this it isn't really contained in that way. So it will be the same structure, so it'll be fat, but it's just a different, or made up of the same stuff, but it's just a different overall structure. So it's being really pedantic, but you wouldn't class it as a lipoma. Cool. That's all the questions done so far. Oh, here we go. This is probably one of my favourite bits because there is a lot of misconceptions around the IT band, and the IT band actually isn't a band, and it is a thickening of the fascia, which is a connective tissue that surrounds the whole leg. Okay, so when you are doing any kind of manual therapy anywhere on the leg, you will have some kind of impact on the IT band because it all attaches. Okay. Morning, Becky. Morning. So let's just show you the bit of a picture. So if you've never heard of the ITB before, the IT band is the iliotibial band. So it goes from the ilium onto the tibia, and it's basically a long tendon. So it's this muscle at the front, the tensor fasciolata. So this is the TFL. So it's not Transport for London. This is the TFL. Whenever I catch the tube, I always It's really sad. I always think of that. So TFL there, this will ruin your life now if you ever go to London. And then on the back is your glute max, gluteus maximus, and the IT band is the long tendon of those two muscles. So usually where you have issues with the iliotibial band or iliotibial tract is around this area here. So this is you've got a bony lump up here, which we haven't covered yet because it's in the hip section, but it's called the greater trochanter. And then just underneath there, you've got a gluteal tuberosity. So it's where the glutes attach into via the IT band. And that area there is usually very sore with people who have gluteal tendinopathies. So that area there is usually problematic. And then down here, where it attaches on the tibia, is called Gerdy's tubercle. So somebody called Gerdy must have named it. And basically, it's the thickening of the fascia that surrounds the whole thigh, and it is also continuous with the whole leg. Okay, so it's continuous, it's all over the place. Okay. Right, let's have a look at this. Just make sure I get the right videos again. Should be in this one. Yep. Here we go, I think. Yeah, here we go. Just move this out of the way. So this is the fascia lata. So fascia lata means white fascia. And you can see why it's called the white fascia, because it's white and it's fascia. So this is a right leg. There's a patella just down there. And this is your IT band. So it wraps around the whole leg. So if we just have a look at this. So there's your TFL at the top. So that's the tensor fascia lata at the top. And you can see how it just goes around everything. Absolutely everything. So there's your patella. There is a thickened part just here, which is the IT band or the iliotibial tract. And there's your iliac crest at the top. So it literally envelops everything. There's Gerdy's tubercle at the bottom. And this is what you normally see in the textbooks. So in the textbooks, it looks like this. It looks like a band, and that's why people call it an IT band. And then you basically get taught to do treatments to this area. This band is inch by square inch is stronger than steel. Something that I've nicked from Julian Baker because I like the way he described it. If you cut a piece of this off and you have two of the world's strongest men with some pliers on either end of it trying to pull it apart, they would not be able to pull it apart. It is absolutely solid. Okay, so when you do treatments to this region and it changes how it feels, you're not affecting the tissue, you're affecting the sensation in the area. Okay, so you cannot stretch the IT band. So if you do IT band stretches, they don't stretch the tissue. This is too tough to be able to stretch. So this is the IT tract or IT band. There's your vastus lateralis muscle. We haven't looked at that yet. There's your biceps femoris. We haven't looked at that yet. But in between there is a septum. So just going to go back a bit. Pause that there. Okay, so if you remember back in the leg when we looked at the muscles of around the shin, there were different compartments. So you had an anterior compartment, a lateral compartment, deep posterior, superficial posterior. Those there are compartments as well in the thigh. So all of your muscles, so the quads, the adductor muscles on the inside of your thigh, and then the hamstring muscles on the back, they are separated by septum, exactly the same as in the leg. Yeah. So that there is the lateral intermuscular septum. So it connects the IT band, so that thick fibrous band, all the way through to the femur, and it creates a divide between the muscles on the front of the leg and the muscles on the back of the leg. Okay, so that's the lateral intermuscular septum. Good question. How does the whole trigger points thing in IT band work? True or false? Easy. False. There's the oh man, that's a whole other just trigger points in general is a whole other uh, a whole hour session, I reckon. There's no such thing as trigger points. They're basically sore spots. So uh, there's no reliable way to assess a trigger point. And if you get 10 therapists in a room, all palpating someone's leg, they will all have um, different thoughts about where trigger points are. So the science behind trigger points is quite sketchy, to be honest. And when you feel a cadaver, so we talked about this last week, when you run your fingers along the muscles of a dead person, there are no bumps in the muscle. You can't, unless they've got a scar, you can't feel anything. It's smooth. So uh, the sensation of a sore spot is and the sensation of tightness comes from the person being alive. So it's their nervous system giving that sensation. It's not the tissue. So that kind of feeling is not coming from the tissue. So any kind of increased tone that you think you can feel is not because there's a knot in the muscle, because there aren't any, unless they've been injured and there's a scar tissue there. Those knots are kind of things that we say to ourselves to rationalize what we're feeling. If you look under ultrasound, you look on an MRI, there's no change in the tissue. So the only reasonable explanation is that it's to do with the nervous system. Okay, so there you go. Long-winded answer for false. Okay, so this is your IT band. And there is Gertie's tubercle just there. There's your TFL again, so tensor fascial lata, and then there's your glute max. Okay, so gluteus maximus will cover when we do the hip, huge muscle. And if I just pause that there, go back a bit. Now this is the bit that is literally a pain in the backside. So that bit there, that attaches onto the femur. So your femur is underneath there. Okay, so there's your IT band. So glute max attaching into the IT. It also attaches to the femur on the gluteal tuberosity and then runs down the leg. Okay, so that bit there is usually, if they have a problem with the glute max, is where you'll get gluteal tendinopathies, because it's the insertion point of the glute max on the femur, and it's usually really really tender in there. Yeah, that's an area to look out for. So glute max, there's your iliac crest all over the top. And there's your TFL. In fact, if anybody in the group, if you wouldn't mind, there is a really good article that talks about trigger points from Paul Ingraham. And so if Dan, I know you've usually got that link saved in your favorites. So if you wouldn't mind putting that in the group, that'd be great. Just so there's a link to that trigger point stuff, because it's still being taught, unfortunately, and there is very little science behind it. So we then I think it really sets the manual therapy world back, because the education is still teaching these things. So then when you start to converse with other clinicians, and they're going, what, you're still talking about trigger points? And you're like, well, I've only just been taught it, and it's really not fair. It's not fair on you. So yeah, there's a really really good article that Paul Ingraham has written. So if you want to have a read about that, then that's really good. Thanks, Dan. Perfect. And it just sums everything up, all of the kind of things that we were taught, and I used to teach it. Go back 10, 15 years that I used to teach that stuff, yeah, there's lots of things that have changed over that time in our thought process about what we're doing. So there is your attachment point for the TFL, all along the iliac crest, and then it attaches into your IT band there. Cool. So hopefully that's kind of dispelled some of the myths around the iliotibial band as well. So if you've got if you've got in your mind that just this strip of tissue that goes down the leg, that's not what it is. It is it's that. Okay, so it's just surrounds the whole thing, and there's just a thickened bit on there. Good question by Stevie. So are injuries more common at the attachment site or on the insertion site? So I guess it depends on what they do. I see a bit. I don't know the actual figures. I don't know if there's been any research looking into the prevalence of them. But anecdotally in the clinic, it's about 50-50. So I usually see runners with a runner's knee type problem. And that's usually what we call iliotibial band syndrome. So the problem is usually not the structure, it's to do with that person's loading of their run. So we had this a lot in lockdown. So everybody was locked down. You had people who'd never exercised at all of a sudden, the only thing that they could do was go out for an hour a day. So they decided to take up running. And then by the third or fourth week in, after doing runs every day, they started to get problems with their knees. And the problem wasn't that they had an issue with the IT band. It was basically they went from zero to doing loads of runs. And so we just needed to back things off a little bit, slow the pace down a bit, and then gradually build them up again. So it wasn't the tissue that was the problem; it was the overload. So usually runners with the knee. You see all sorts with gluteal tendinopathies. To be honest, it can be a hormonal thing. So if you get a lot of perimenopausal, menopausal women who suffer with gluteal tendinopathies, and it's there's a thought process that it's to do with the hormones. So and tendon issues like plantar fasciitis, Achilles tendinopathy tend to be more prevalent in that type of age range. So it depends. It's more an irritation than an injury that I would see. Again, just to be a bit more specific. Okay. Yeah, cool. Yes, there was. Yeah, so there was a chat in the STA group with Paul Ingraham and Matt. God, I can't remember his name. Someone will put it in there. Matt, my mate Matt, who I can't remember his surname. Right then, so let's have a look at this next one. Just make sure I get the right one again. Yeah, here we go. So that was IT band. And then the bursa. Okay, so you can't see bursa on cadavers because the bursal fluid dries up. And so you will see them on a fresh dissection. So if you see someone who's just recently died, you'll see them on that. You won't see them in usual anatomy labs. But these are the bursa around the knee. Just move me out here. So we have suprapatellar bursa. So that's that's the pouch at the top that we were talking about. You've got a subcutaneous prepatellar bursa. So this is your kind of housemaid's knee. Okay, so if you kneel on that, you get this a lot as well, or irritated a lot with plumbers, carpenters, carpet fitters, those kind of guys that are on their knees all the time. That's why they wear the knee pads to protect their bursa. Otherwise, they'll get a huge bursa on their knee. They're just irritated. You've got an infrapatellar bursa. You've got a deep infrapatellar bursa. So there's your patellar tendon just there. And so there's one in front of it, one behind it. Obviously, Hoffer's fat pad is just in here as well. You've got a semimembranosus bursa just at the back there. And then a pes anserinus bursa as well, where three of your muscles of the thigh attach into your tibia, which we'll have a look at later. So there's quite a few bursa around the knee, and they can get irritated, usually with impact or sustained friction. So on the other side of the leg, you've got an iliotibial bursa. So just down here, iliotibial bursa. So where Gerdy's tubercle is, there's a bursa there as well to try to prevent the friction of the IT band on the tibia. Okay, so there's a few places where that bursa can get irritated. This was just a little bit on the patella from last week. So talked about different, just move me out the way there, talked about different sizes and shapes of the patella and what it does. So we saw a video last week. It increases the lever arm for flexion and extension. So without a patella, your muscles would have to work really hard to extend your leg. But with a patella, because there's this sesamoid bone there, it doesn't have to work as hard. So you get an increase in power. There's something called Lombard's paradox. I don't really have time to cover it today. I might do it next week actually. But have a look at Lombard's paradox. It's to do with the muscles that cross two joints. So rectus femoris rather than your vastus muscles, and your hamstring, all of your hamstring muscles cross two joints. So there is this kind of, well, this paradox, this thought process that rectus femoris and the hamstrings don't actually concentrically and eccentrically contract because they cross two joints. And yeah, we'll talk about that next week. Yeah, and then you've got patella differences. So we've got alta, barger, squinting, frog-eyed, spinning, lateral maltracking, medial maltracking. So there's lots of different positions of the patella and sizes of the patella that may increase the frequency of it dislocating. And usually it's a lateral dislocation if it does go. Okay, so that and again we briefly touched on that last week. We've seen that video already. Okay, last bit of this. Haven't even gotten to the muscles yet. Blimey. Okay, so we talked a little bit about this last week. So we've got, if you remember, if I just move me onto the big screen a second. Okay, so if you remember, if having a look at this, so this is the medial side, because there's the fibula. This is the lateral side. And you can see that the medial condyle here is longer than the lateral condyle just there. So there's a gap in here. So that means that the knee can't work like a hinge. Because for it to be able to work like a hinge, these would need to be the same size, so that it's literally like a hinge on the door. But as you straighten the leg, the medial part of the knee is going to make a contact first, and what that then does is it spins the tibia. So as you straighten your leg, the medial condyle, femoral condyle will contact the medial tibial condyle. And then as it comes up, you'll then get a rotation and a spin, and the tibia will laterally rotate. And that then locks the knee. Okay, so I mean, it's a bit exaggerated because there's no tissue in the way of this. But as you come up, you'll get a lateral rotation, and then that will lock the knee in place. Okay, so that's called the screw home mechanism of the knee. And when you're in that position, when it's locked like that, you can stand there, and then all of your muscles that connect over the joint they won't disengage, but they'll save energy. Okay, so and if you've ever used this example before, if you've stood in the queue for going into school for lunchtime, and then you stood there just minding your own business, and someone comes up to you and just taps the back of your knee, and then you whoop, and your knee kind of goes, and it's because when you're there stood like that, you're resting on your passive structures. Okay, so the muscles can back off a little bit because they don't need to work as hard when the knee is screwed home, and then the cruciate ligaments are tight because they've been they're in that extended position. Your medial and lateral collateral ligaments are tight, and the joint capsule will help provide stability of the knee in that position, so then your muscles can conserve some energy. So that's why when you just get a little knock on the back of the leg, it takes a little while for then your muscles to kick in and then stabilize the knee. Okay, so it's an energy saving mechanism when you're stood for a long period of time, which is really useful. But also you need something to unlock the knee when you go into flexion again. And that unlocking, so that medial rotation at the end of extension, so lateral rotation to lock it, medial rotation to unlock it, happens because of a little muscle at the back of the knee called popliteus, which is what we'll have a look at in a second. Okay, so that's the screw home mechanism of the knee, and you can have a look at that. There's loads of videos online for you to see. So yeah, so the knee becomes what we call a close packed position. So basically, it's the most congruent the joint will be. So the joint surfaces are nicely knitted together, basically. The cruciate and collaterals become taut, the knee becomes locked out, and it negates the need for muscle work in stance. So it basically saves you energy. Larger surface area of articular surfaces in contact during end range extension. So you're basically resting on the passive structures, which is all the stuff we've just looked at. Okay, so that's that. Just going through that one. Yeah, we talked a little bit about this as well, the kind of Q angle and the varus and valgus position, or varus and valgus positions. I described them last week, so here's some pictures. So a valgus position is where the knee comes inwards, and a varus position is where the knee comes out. So if you have a look here, so on the inside of the knee, in a valgus position, there is the inside of the knee is opened up. So that is the way that we stress the joint when we're testing the medial collateral ligament. We want to take it into that kind of position so that it opens up the inside of the knee, and we're testing the integrity of the ligament. And the opposite is true for this one. So in a varus position, you would go the other way to try and open up that lateral ligament to test the integrity of that one. Okay. We used to think that these positions were harmful. We are now having a bit of a change of opinion. There is a really good knee physio who works in Salford. I'm forgetting everybody's name today. Oh, what's his name? Lee Harrington. And so Lee's done a load of research on dynamic valgus knee positions. He works a lot with Premiership football, and I went to one of his lectures a couple of years ago, and he was basically saying that knee valgus is completely normal. We need to train people in knee valgus if they play a sport where you have to change direction, because if you don't prepare them for that position, so this knee valgus position, and everything you do is with your knees dead straight because that's what's perfect, he said they will be unprepared for the game. So you actually need to stress the tissue in this position to prepare people. The problem is not the position. The problem is them being underprepared for going into that position. Okay, so that's the kind of change of thought process that we're going through now. Cool. We'll finish on, because it's coming up to 50 minutes, so we'll finish on this. It was supposed to be the muscles of the knee, but we're finishing off all the passive structures. Never mind. So this is something I think that was mentioned last time by Becky. Oh, actually, I've just seen some questions come in. Sorry, guys, I've just missed these. So Simon has said, is housemaid's knee the same as fluid on the knee? Yes, it depends where the fluid is, though. It's kind of one of those generic terms, isn't it? So housemaid's knee is specifically to do with the prepatellar bursa. Okay, if there's fluid anywhere else on the knee, it could be because of something going on in the knee joint, and then it's swelling. Okay, so it's not specific enough a question. That's not your fault. It's just that's what people say, isn't it? Yeah. So, oh, I've got fluid on my knee. It's like, well, which bit of your knee? Okay. So we need to be a bit more specific with exactly where it is. So housemaid's knee specifically prepatellar bursa, but there can be fluid anywhere. So Jane, does anything in particular happen in the ankle during the screw home mechanism? Only if you are in a close chain position. But even then, you're not really going to influence that mechanism too much. So what I mean is that in an open chain where your leg is free to move, you can laterally rotate really easy. When your foot is on the floor, and then you have to basically use the hip muscles to um, assist the knee in unlocking. So as well as popliteus, you use the hip as well. Um, if you lack dorsiflexion, that will change the closed chain coordination, but you would still be able to unlock it. Yeah, it would change the biomechanics a bit, but you would still be able to unlock the knee. If there's anything you're particularly questioning there, your thought process, then maybe I'll be able to help out a bit more. Do, 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 do. Apes can't do it. Takes a lot of energy to stay on two legs. Yeah, that they can't lock out their legs. Ah, interesting. Okay, that's a good. I didn't know that. Valgus position. Yep, particularly more common in women. Yep, and yeah, because of the shape of the hips, and that's all to do with the Q angle. So we will look at that a bit more when we get to the hip and the pelvis. Uh, and again, female footballers are more likely to get medial collateral ligament injuries, medial meniscus injuries, and ACL. And we used to think it's because of the position, so the valgus knee position, but now they're starting to. A few of my friends work with professional football, and they're starting to really condition the females now because of that anatomy change that we used to think would predispose them to that injury. And now they're training them in knee valgus and preparing them for that position, so it's reducing the risk of injuries. So it's quite interesting. So the anatomy will predispose you to it a bit, but you can negate it by conditioning them. Okay, so that's a good point. Tracy, does acute angle valgus varus have an impact on the screw home mechanism? It shouldn't do because of the shape of the knee would determine your own screw home mechanism. So it's so if you had a valgus position, then your femur will have changed in some way, maybe with some kind of retroversion, anteversion in the femur, which would, and then maybe a tibial torsion as well. So that there are lots of different makeups of everybody, and you adapt to your anatomy. Okay, so it shouldn't impact it too much. Um, affects the ability to catch a big, yeah. Okay, so just mean in a closed position, the tib fib laterally rotates, but the foot doesn't move. There must be some mechanics. Right, okay. So the fibula, just move me onto this one. So the fibula sits underneath the tibial plateau. Okay, so if I just get that there. So because the fibula sits underneath the tibial plateau, it doesn't get impacted in the rotation at the knee. Okay, so yeah, there may be an influence on the ankle from the biceps femoris because of where the hamstring attaches. So if there's an issue with the hamstring, which limits the movement anteriorly, posteriorly of the fib head, then that can affect ankle dorsiflexion. Yeah, but because of the position of the fibula underneath that tibial plateau, it shouldn't impact that screw home mechanism. I haven't read anything that does. Okay, good. Well, you've been an interactive bunch this morning. It's been good. Cool. And we're nearly at an hour. Blimey. Okay. Don't time fly when you're having fun. So what was supposed to be the muscles of the knee has changed into passive structures as number 2. So we will definitely be looking at the muscles next week. I hope you guys all have a really good Christmas. And yeah, hope nobody gets COVID. And that's the thing. I'm paranoid at the moment about going out places and getting that. So yeah, I hope you have a really good time and you get everything that you want from Santa. And I will see you next Monday, 10 o'clock.